So now we're looking at the megaloblastic anemia set of things, right? So that was in itself quite a long list of various types of anemias you could have, right? And they were all mainly related to DNA issues, right? So that's the core, the core pathology you're going to look for, something that the person is doing or some disease process that the person is undergoing, your patient is undergoing, that may be altering their ability to make DNA quick enough. You replicate your white blood cells at a very rapid manner, right? So if anything happens to the DNA replication, you end up causing red blood cells to look really big because the red blood cells end up growing faster than your DNA is. The way you want to think about it is that imagine you have, I'm going to draw the DNA and then the red blood cell, right? So there's two different pillars I'll draw. Imagine that they're both growing until the more important thing finishes. The more important thing is the DNA itself. So imagine it's going to take a very long time. So usually maybe it only takes just to set a comparison, maybe it only takes this length to finish making the DNA and the red blood cell at the same time, and then you get good, normal, healthy red blood cells that look like this. All right. Now imagine at the same time in these patients, in this group of difficulties in the megaloblastic area, it may take a significantly longer time to make the DNA. Here it looks like it's almost double my original arrow, right? My original arrow was maybe like this. So then the red blood cell was also originally equally as long, right? Because once your DNA is done being replicated and everything, your red blood cell is ready. It doesn't take much to create a simple red blood cell in the sense that your heme is already good here, right? The heme production is working fine. So everything's put together, no organelles necessary, your red blood cell is good to go. But in this secondary case where you have your DNA issue, it takes a lot longer to create DNA. So then it also takes a lot longer to finish producing the red blood cell. And at this point you end up getting, as you could tell from the amount of time it's taking, significantly bigger looking red blood cell. Right? So that's kind of what causes these people to have megaloblastic anemia. So there's two key things that you're going to see in your questions, and the list of disorders that they related to are going to be the initial presenting symptom that your patient is going to come in with. So they tell you it's impaired DNA synthesis secondary to vitamin B12 or folate deficiency. Right? Either one of those two deficiencies are the most commonly seen things that lead to megaloblastic anemia. Now imagine vitamin B12 deficiency. This is caused by either intestinal malabsorption, so it's absorbed in the ileum. The ileum is messed up in Crohn's disease, right? That's one more thing right there. It's also going to require your intrinsic factor. So traditionally, vitamin B12 deficiency is from pernicious anemia, autoimmune destruction of your parietal cells, which actually make intrinsic factor. Gastrectomy, so food isn't even passing by your stomach correctly, and vitamin B12 isn't being absorbed because of that. Pancreatic insufficiency, someone who has pancreatitis, pancreatic cancer, or stone that's lodged at that duct right where your biliary and pancreatic stuff would go into the second part of the duodenum. Crohn's disease, as we said, because most people have ileal disease and Crohn's disease. Celiac disease, which messes up the entire lining of the stomach. Topical, this is supposed to be tropical, there's an error in their spelling. So tropical sprue, which is pretty much usually some bacteria related kind of damage to the stomach lining. Tapeworms or low dietary intake, which in America, this is usually the other most common thing. Right? So it's people who are vegan or have a vegetarian diet and they don't take enough red meat, which is where we get the bulk of our B12. B12 is not really stored in the liver that much. Right? B12 deficiency is pretty common because you don't store such high amounts in your liver, so it can also just run out more quickly. Folate deficiency almost entirely is due to alcoholism. Right? It could also be due to low dietary folate, which could be a case scenario for someone who's pregnant. They have increased demand of folate, so if the demand isn't met, they run out of folate. Malabsorption, again, because vitamin B9 is also absorbed, so it was DJ, ice is in 4, so J and I, right? So jejunum. In your jejunum is where you absorb folate. So if someone had to get a jejunal resection or their jejunum is messed up for whatever reason, some kind of IBD issue, then they're going to have that malabsorption. Malabsorption could also be due to other things wrong in the stomach, or just not releasing enough bile and pancreatic secretions. You can also see this in psoriasis. So in psoriasis, it happens because psoriasis is actually a skin disorder, an autoimmune skin disorder, where you're going to need more folate once again, right? Because you're going to try to keep making those skin cells correctly and run out of folate and all that DNA forming issues. Sulfa drugs also cause folate to run out, so this is also revised here. So if you look back to, once again, the very first thing you ever look at in biochem, your molecular section, right here, you can see where you actually need folate, right? So THF is tetrahydrofolate. You need it to donate a carbon to actually convert your UMP to TMP, which is thymine, thanks to thymidylate synthase. Now, if you don't have folate, then dihydrofolate reductase can't do its thing, nor can thymidylate synthase. Yeah, so this is where you actually need your folate. And then you see TMP is mentioned here. That's usually given with sulfamethoxazole, trimethylpurine sulfamethoxazole combination medication. So that's something that plays a role over here. And of course, phenytoin as well, another medication that can make you run out of folate. Drugs that interfere with DNA synthesis, like your chemotherapeutic methotrexate or 6-mercaptopurine. Once again, you're seeing the methotrexate right here. Right, you see your 6-mercaptopurine right here. Any of these guys that stop you from correctly making DNA may also lead to megaloblastic anemia, for the same reason that I showed with the upward-facing arrows earlier. Presents with the general anemia things: fatigue, pallor, glossitis, chelosis, diarrhea, loss of appetite, and headache. The diarrhea aspect won't be just due to B12 or folate deficiency, but it'll be due to something else that's actually causing your B12 or folate deficiency, so such as the tropical sprue. B12 deficiency also affects the nervous system, right? That was the key difference between folate versus B12 deficiency. However, keep in mind that B12 deficiency also can often mimic vitamin E deficiency, which also causes neurologic symptoms. So these are things that you would have to go back to your nutrition chapter to revise, right? So if we look at, let's see, first thing right here, we have B9. Right? B9 found in vegetables, absorbed in the jejunum. There's a small reserve pool stored primarily in the liver, and it can easily run out. What else did they mention here? And one of the key associations that probably won't get tested in CK, it's more of a step 1 topic, is this relation to homocysteine and methylmalonic acid. The B9 actually affects homocysteine. Right, so you're going to have more homocysteine. And why would you have more homocysteine? That's actually shown right here in this B12 related diagram. So normally what you do, you can see in here, you have your methionine that becomes eventually homocysteine, right? And this homocysteine, with the help of B12 and B9 both, will become methionine, which is used for protein, right? So you see, if you don't have, now here as well, homocysteine is elevated. If you don't have B12 or B9, you start accumulating a lot of homocysteine because you don't have, you need both guys here. This is B12, B9 does a different thing that's irrelevant to THF. You need both of them here to convert homocysteine to methionine, right? This is one of the things related to homocystinuria, which is caused by so many different case scenarios. So many different things can cause homocystinuria, right? So usually when you treat homocystinuria, you have to give all the vitamins because you don't need to waste time trying to figure out what exact thing caused the homocystinuria. You just give everything, B9, B12, B6, everything, and then their homocysteine should get used up and converted to whatever it needs to be converted to, right? B6 will help it be converted to cysteine, for example. So in B9 deficiency, the only thing that goes up is your homocysteine. But in B12 deficiency, which is due to usually the vegan diet or pernicious anemia, you're going to have an increase in both homocysteine as well as methylmalonate. Right? Methylmalonate is the other thing that's going to go up, as you can see over here, because methylmalonyl-CoA needs to become succinyl-CoA, which requires B12. This mutase enzyme, it's called a mutase because all it does is it takes the methylmalonyl-CoA and just changes up the configuration of the molecule, and it becomes succinyl-CoA. Right? The same succinyl-CoA that you can use in TCA, or the same succinyl-CoA that we combine with glycine to create heme, as we saw earlier with our porphyrin ureas, right? The porphyrias. So that's stuff you definitely want to make sure you feel comfortable about. You want to revise that. You want to keep these little cycles in your mind You don't need to remember it perfectly, but you do need to keep in mind the connections that some of these things have to other cycles, especially important in step 1. Now we see here that B12 deficiency can cause subacute combined degeneration, which makes you lose your dorsal columns, which are the sensory ones in the back, lateral corticospinal tracts, which are for actual movement, these are efferent, and then the spinocerebellar tracts, which can lead to cerebellar issues like ataxia. So that's your B12 deficiency. Now you can compare that to vitamin E deficiency, which also has demyelination of your posterior columns. Here you lose your posterior columns and your spinocerebellar tracts. This is different. You don't affect, as you can see, you don't affect the corticospinal tract, which was your efferent tract that makes you or allows you to be able to move. That's not affected here. One of the biggest differences between vitamin E deficiency and vitamin B12 deficiency will be the type of anemia. So we're going to see this pretty soon. Vitamin E is an antioxidant. It protects your red blood cell membranes from free radical damage. If you don't have vitamin E, you get this hemolytic anemia where you're going to cut up all your red blood cells and then you're going to find more heme, more bilirubin, and so on, as we've been seeing all along. Right, so those are some key things you want to watch out for to be able to differentiate between one over the other. In CK, the same questions that you used to get in step 1 will pop up. Which vitamin deficiency? But instead of asking you which vitamin deficiency, they'll just ask you what's the next best step, which will basically be to give them the vitamin they're out of. Right? So that means you still have to know which vitamin they're out of before you can start giving them something. It would be pretty useless to give someone B12 if their deficiency is vitamin E. Because you could give them B12, they'll make more red blood cells, but then if they're still vitamin E deficient, they'll still have the hemolysis of the brand new red blood cells they made, and they'll continue killing it all. Right, so that's kind of what they're breaking down for you here. Right, there's a combination of symmetric posterior column loss causing sensory and LMN signs, lower motor neuron signs, as well as symmetrical corticospinal tract loss, which causes upper motor neuron signs. So they're going to have a positive Babinski's, for example. Things go up. Best initial test, as usual with any anemia, is just to do the CBC, and you're going to have your long list of up and down arrows again, right? All the parameters with up and down arrows. And you can see here, they're mentioning the difference between the two, right? That in B12 deficiency, methylmalonic acid and homocysteine both will be elevated. Whereas in folate deficiency, the methylmalonic acid is fine. Right? Methylmalonic acid, you can think of this as the things you need to be able to make your myelin. Alright, so that's kind of the deficiency we were seeing right here. Right, methylmalonic acid deficiency. If your methylmalonic acid builds up, you mess up your myelin. So you need to convert this into succinyl-CoA eventually. Otherwise, this stuff builds up and kills your myelin, which is why they have their subacute combined degeneration in B12 deficiency. Right, and homocysteine building up, this usually just means that you're not going to make methionine. If this conversion doesn't happen correctly, you don't make THF. If you don't make THF, you can't do DNA synthesis. As we saw from when we went back to biochem and molecular, that THF was necessary in that last step to convert DUMP to DTMP. Again, constant revision is very key here to be able to talk about these things confidently and just have the good recall of these things in your mind. So what do you see in these people on CBC, where you're going to see red blood cells with an elevated MCV, and hypersegmented neutrophils, one of the key things we've been looking at all along, right? This is a very extreme case here where you have far more than 5 to 6 lobes, right? 6 lobes they're mentioning for this one. 6 or more is a definite giveaway for megaloblastic anemia. You could see 5, up to 5 is still slightly, borderline pathological right there. They tell you that you're going to have low hemoglobin, high MCV, low B12, or folate, either one. Low reticulocyte count because you're not making a good number of red blood cells. Could have pancytopenia if it gets very severe. And you're going to have elevated LDH, right, which lactate dehydrogenase is a sign of cell death, which is what's going to be happening in these people. And indirect bilirubin will go up because of the cell death, right? Those red blood cells are not really going to be that functional, and they'll be getting killed because they'll be too big, right? So these other things you're seeing around here, 1, 2, 3, and this one in the corner probably also are your red blood cells. Right? You can see there's barely any central pallor to it. It's just big. Serum vitamin levels should be measured, and adjunctive tests, including MMA and homocysteine levels, can be assessed if vitamin levels are non-diagnostic and clinical suspicion persists. But to order these tests, you would have to have the clinical suspicion. You have to think of this. Bone marrow sample reveals giant neutrophils and hypersegmented mature neutrophils, but you probably won't do a bone marrow biopsy because, again, it won't be necessary. The anti-intrinsic factor and anti-parotid cell antibodies in pernicious anemia are another thing you could find. And then they mention here the Schilling test. Now, the Schilling test isn't really done anymore. It's a very lengthy, time-consuming, bothersome test that you can do. I used to talk about it over here, but I don't know if I... Yeah, no, I don't break it down here anymore. But it basically, so this pathway actually is pretty helpful to understand what the Schilling test would be. So intrinsic factor from your gastric parotid cells bind B12 in the duodenum, and this B12 intrinsic factor complex binds receptors in the distal ileum. So there's 2 places in your GIT that if they're messed up, you're not going to absorb B12 fine. Actually 3 places, your stomach also, right? Your stomach has to have parotid cells, your duodenum has to absorb it, and your ileum has to finally bind and take it into the body. So when you do the Schilling test, you do a long list of things, one after the other, to see if the anemia gets corrected. So they tell you here this test is rarely performed, but its interpretation is tested. So you do see this. So on the Schilling test, it's almost like we do this. On your step, the Schilling test is like an everyday thing you practice in clinic, so you have to know it very well. So let me actually find it and talk about it in good depth before we move forward, because it will be tested. Schilling test. Okay, let's see. I think this does the job right here. Okay, maybe I think this might be good. Let me paste it right here. Okay, so here they tell you. Of course, first explain the procedure. Step 1. Administer an oral dose of labeled vitamin B12 to the patient, followed by an intramuscular dose of vitamin B12. Collect the 24-hour urine and record the level of B12 in the urine. Normal level of vitamin B12 in the urine, then possible diagnosis is vitamin B12 deficiency caused by poor intake. But if you have a high level of B12 in the urine, that means that it all just went through the intestine, didn't get absorbed, and that means you have some sort of pernicious anemia. For some reason, you're not absorbing it. Maybe pernicious anemia, maybe damage to your actual lining, right? So you don't know for sure yet. So let me actually write that right here. If you see normal levels, you're good. That means that this person just needed to eat more vitamin B12. But if you don't see normal levels, if you see too much in the urine, then it could be pernicious anemia, PA, or it could just be bad absorption, malabsorption, right? Maybe because something's wrong in your ileum. So now you have to figure out which one of those 2 it is. So you go to the next step. If an abnormal urine content of vitamin B12 is recorded, proceed by repeating step 1, but also administer an oral dose of intrinsic factor. Now, if giving the oral intrinsic factor fixed it, then it's very evident the problem must have been pernicious anemia. If even after giving the oral intrinsic factor, you still notice that there's problems, right? If the level of vitamin B12 still remains low in the urine, the diagnosis of intestinal malabsorption should be considered, and further tests are done to find the actual cause, right? So that's all it is. It's a very straightforward, simple thing. You're going to give vitamin B12, see what happened. Right? And then if you see a lot of it in the urine, that means they didn't absorb it. Because it shouldn't be in the urine, you should be absorbing it pretty well. Let me see. So now maybe the problem is pernicious anemia, so you give them intrinsic factor with the B12. And if it's still not helping, then the problem wasn't B12, the problem wasn't intrinsic factor, the problem must be that they're unable to absorb it. Maybe something's wrong in the ileum, maybe something's wrong in the second part of the duodenum, maybe the lining of the stomach isn't good, one of these things. All right. Treatment, correct the underlying cause, very straightforward. You give them B12 and then figure out why they're unable to absorb it, give them B9, figure out why they're unable to absorb it, and stop whatever the problem is that's not letting them absorb it. All right. Next thing is your hemolytic anemia. So these occur when bone marrow production is unable to compensate for the really rapid destruction of circulating blood cells. Many things can cause it. Notoriously on STEP is usually G6PD deficiency, but it could also be due to PNH or spherocytosis, where your spleen is killing your red blood cells because they're too spherical. So as they pass by the spleen, the splenic, I forget what the part of the spleen it was, but through the spleen filtering, it gets ripped up. Right? It could also be sickle cell disease, where all your red blood cells are really weirdly shaped, so they get stuck together and once again enter the spleen and get killed over there. Or it could just be an autoimmune anemia, discussed separately later. Right? And then they just break it down for you. They're not going in depth here, so we'll go back to the step 1 book to look at it. But microangiopathic hemolytic anemia could be TTP, which we discussed, HUS, which we discussed, and DIC, which we discussed. These are all microangiopathic, which means that these are occurring within blood vessels. Right? And we saw what happens in these conditions already. You could also have someone who has mechanical hemolysis, where maybe they got an aortic valve replacement or a mitral valve replacement, and then that valve is now not so good anymore. So as blood is passing through the valve is acting like a knife and cutting those red blood cells up. And that really sucks, because remember, when blood is passing through valves, it goes with high pressure. So if your valve is acting like a knife, all those red blood cells are getting chopped up very, very, very quickly. Other things could be malaria and hypersplenism, where again, you would know if the patient has malaria. They're going to have fever. They're going to maybe have travel history to one of these endemic areas, somewhere in Africa where they might have even gotten the malaria. Or you can get malaria outside of Africa too, but notoriously in steppe, it's usually somewhere in Africa. You can even get it in India, Pakistan, stuff like that. So let's actually go back and revise a little bit of these guys just to have it down. So in step 1, those discussions are throughout the book, not in one location. For example, G6PD deficiency is something that you discuss in the metabolism section, right over here. So in these people, the number one thing is one of these oxidizing agents, or they have infection. Right, so any of these medications, or flavabines, sulfonamides, nitrofurantoin, right, anti-tuberculosis drugs like isoniazid, or having infection which cause distress in the whole body and inflammation, all of these things could lead to G6PD symptoms just becoming rampant. So what's the problem? Why is that happening? So look at the enzyme itself. G6PD takes glucose 6-phosphate, forms 6-phosphoglucanolactone, and in doing so, it's able to recycle your NAD plus to NADPH. Right, so basically, you took the H and added it to it. That's all you did. You added an H to it. So now you have an NADPH that your glutathione reductase can use. So the problem with G6PD deficiency is that they're unable to recycle glutathione, because without G6PD, you get this domino effect of all 3 of these enzymes not working. So if this first enzyme runs out, this next enzyme won't be able to work either, because it won't have any NADPH. It needs NADPH. What does it do with NADPH? It takes your used oxidized glutathione and converts it into usable, recycled, reduced GSH, glutathione. This is the GSH we need. We won't be able to make any of that. Without this enzyme won't work either. So what's the problem with that? Well, this enzyme was needed to take H2O2 and make it into water. H2O2 is actually the guy that yields a bunch of radicals that are going to go kill your whatever infection, right? So you will fight the infection, but then you won't be able to turn off the fighting mechanism, leading to hemolysis, right? So that's the key thing here. You end up seeing bite cells, right? So you're seeing red blood cells that have a little portion bit off of them. The portion that's been bit off of them was actually the portion that was holding the Heinz body. So you basically bite off in the spleen. Splenic macrophages are going to bite off. Oh, this is the part I was talking about, the splenic sinus, right? The sinusoids. So in your spleen, you can see in this picture here, as things are passing through the spleen, things are passing from left to right. As it's passing through the spleen, your spleen bites off the portion here that had this Heinz body. Right, so that's kind of what you're going to look for in your questions with G6PD. PNH, paroxysmal nocturnal hemoglobinuria, is something that's discussed in immunology right here. These are the people that are going to have problems with blood in the urine. Right? So you can see that right here. This is the bloody urine. A defect in the PIGA gene preventing the formation of GPI, something that actually anchors complement inhibitors. Back in immunology, you learned that your complement system kills pretty much everything that doesn't have MHC on it. Your red blood cells don't really have MHC on it. So your body would see red blood cells and think, oh, that doesn't look like it's ours. It's probably something foreign. Let's kill it. That's why your red blood cells have these anchors, right? The GPI anchors. What is it holding? It's holding complement inhibitors like your decay accelerating factor and the membrane inhibitor of reactive lysis. Those are the 2 guys you need, CD55 and 59. Those inhibiting factors prevent your red blood cells from being killed by complement. If you don't have those guys, or you don't have the actual anchor that's holding these two guys onto red blood cells, then red blood cells can now be destroyed by complement. Right, so you, again, anytime you have hemolysis and all those hemolytic anemias, you're going to see this other factor with your up and down arrows. It's going to be called a decreased haptoglobin. Haptoglobin is there in all of us. We all have haptoglobin. Its job is to bind hemoglobin. So if you have a lot of free hemoglobin floating around because of hemolysis, the haptoglobin binds this. So if you have haptoglobin, this is free hemoglobin, you're just going to bind it, you're going to be recycling it or something. Once all your haptoglobin binds to hemoglobin, you run out of haptoglobin. That's why you have low haptoglobin. They ran out of haptoglobin because their haptoglobin was out there binding a bunch of hemoglobin. Right here you can see this NBME question. 33-year-old woman comes to the physician because of 2-month history of easy fatigability and dark urine. So fatigability and dark urine I would highlight in the mornings, which means it happened overnight, aka nocturnal hemoglobinuria. She has not had fever or weight loss during this period, so since she hasn't had fever or weight loss, the weight loss part tells you it's probably not some kind of cancer thing, and since she didn't have fever, the question probably is not G6PD related. See this answer choice here? Because infection can spark up G6PD deficiency related hemolytic anemia. She hasn't traveled anywhere, so it's not going to be malaria, right? She takes no medication, so again, it's not G6PD, which can be sparked up, initiated, right, triggered by medications. Her temperature is fine, pulse is high, right? So you always highlight any of your vitals that don't look normal, and blood pressure is fine as well. Physical exam shows scleral icterus, which is a sign of jaundice type of thing. And this is happening because she's killing all her red blood cells, so all the heme is being converted to bilirubin, as we've talked about. They look at her labs. Clearly her hemoglobin is low, so there is anemia. Her hematocrit is actually okay, which means she's making red blood cells. So the problem isn't that she cannot make red blood cells. You would get rid of any answer choice that says she might have some kind of bone marrow problem. You looked at her serum bilirubin, and of course her bilirubin is very high, and the majority of it that is very high is a lot of indirect, which means that she's just making a lot of indirect bilirubin because she has a lot of heme that's being converted to indirect bilirubin. But the indirect bilirubin is being managed correctly. Everything is going okay in this patient. And then the urine has blood. The result of a direct Coombs test, which is going to be very critical even in NCK. They did a Coombs test and it was negative. That means that whatever hemolysis she's having isn't due to antibodies. That's what the Coombs test is for. Your Coombs test looks at in this case scenario, it would look at your red blood cells to see if there are antibodies stuck on it, because the antibody must have been what killed it. So that was negative. Then they did another test called the acidified serum test. This is a very rarely mentioned topic, but of course NBME brought it up. So they did an acidified serum test and that was positive. But unfortunately, this didn't mean much for most students because no one knew what an acidified serum test was. Then they go on and tell you which of the following best describes the underlying cellular cause of her condition. Well, even if you didn't know what the acidified serum test is, just by ruling out the fact that none of the other things that we know about could have caused it, the only thing that's left is this, PNH. So the correct answer here was C, defect in the cell membrane anchor protein, which is GPI. The answer could also be a defect in decoxyribonucleic factor, defect in MIRL, defect in some form of complement inhibitor, etc. Many different ways to rephrase this answer choice. The acidified serum test is also known as Hame's test, but you still really don't need to know what it does. Right? You don't need to worry about it, so I don't even talk about it. But that's kind of what this is how you evaluate what might be causing the anemia. So you could learn from the question, right, that the list of things they did. They took a lot of history to see, does she have any medications? Does she travel? Right? Does she have fever? Because then those are all things that would guide your suspicion towards either G6PD deficiency, malaria, something else, right? Anything else. So none of that was really the case. And then, of course, they ordered a Coombs test to see if maybe she has antibodies that are killing it. These are the things you would be doing over here as well. Right, what else would we talked about G6PD, PNH. Okay, spherocytosis we'll see soon. So they go on to explain now, right? Diagnosis, lab test. You have your FBC, reticulocytes, electrolytes, liver function test, and haptoglobin, as well as urinary urobilinogen. How much urobilinogen is actually going in your urine. This is the stuff we talked about earlier for how your heme is metabolized all the way to urobilinogen in the urine and uro something else that goes in the feces, giving them the correct colors they're supposed to have. What you'll see is a low hematocrit, right, in most of these people who have hemolytic anemia, but it won't be significantly low, slightly low, not too low, like 35% we just saw in that question. Elevated lactate dehydrogenase because cell death is occurring. High indirect bilirubin because all the heme is being converted into indirect bilirubin at a very rapid speed, too fast for your body to metabolize this or convert this into direct bilirubin. A high reticulocyte count, which means that you're making red blood cells, so your bone marrow is working fine. Low haptoglobin because all the haptoglobin is binding to the free-floating hemoglobin that leaked out of your dead red blood cells. You can check. There's a chance there might be folate deficiency. Right, folate is used from increased cell production. So since you have an increased reticulocyte count, you end up using a folate deficiency. Very critical to watch out for this. Right, don't get tricked. If your patient has low folate, it doesn't directly mean that that's the cause of their anemia. They could have low folate because the anemia caused low folate. It can go either way. So how would you differentiate? Well, a person with folate deficiency would have megaloblastic anemia, right? Whereas here, this is a person who has hemolytic anemia, and in efforts of replenishing their red blood cells, their folate demand is high, so they used up all their folate. Okay, they can also have hyperkalemia, which occurs with cell breakdown. Right? Remember how ATPases work? The mnemonic pumpkin, you pump K in to cells. If the cells are dying, all that K leaks out, so you get hyperkalemia. Urine is dark with hemoglobinuria, and there is increased excretion of urinary and fecal urobilinogen because you're making so much heme. Converting so much heme into bilirubin. A slight increase in MCV caused by large reticulocytes is possible. This occurs, remember, again, they're going to throw these things at you to confuse you into thinking it's a megaloblastic anemia, but a person with megaloblastic anemia wouldn't necessarily have a low haptoglobin or even a high reticulocyte count for that matter, right? So this MCV here is occurring because they're rapidly trying to make red blood cells and they're not doing a good job at making them. So as we saw, trying to make red blood cells very, very quickly caused them to have folate deficiency, which in turn led to MCV being bigger, right? They're having the DNA difficulty now. So hemolytic anemia can eventually lead to some presentations that overlap with megaloblastic anemia, but the two guys, it's like when you draw circle graphs, right? When you draw two circles like this, there is some overlapping area, but each circle is very different. There are things that are different from each one of these two case scenarios, and that's what you want to focus on. When you do a peripheral blood smear, those blood films will show you hypochromic, microcytic anemia, sickle cells, schistocytes, or any of these other things depending on which case scenario the patient has, right? So we talked about G6PD deficiency having Heinz bodies and white cells. For these patients, you have to get rid of their spleen, otherwise they're going to kill all their red blood cells. For spherocytes, you're going to have really big spherical cells, as you see here, the ones that the red arrows are pointing at. Right? Super round, it's like globular, so as it goes through the spleen, it gets ripped up. So for spherocytosis patients, you also get rid of their spleen. Let me see what else. That's basically it for that. You could order a direct Coombs test to see if there's any antibodies on it, and then you'll know. And the treatment just varies based off of what thing caused the hemolytic anemia, right? We talked about G6PD already. We looked at all the things that cause it, right? There's a table here to further explain some things you might see. One of the common things patients will present with are these things: that pallor, fatigue, dark urine, and they have weird back pain. Right? That's usually another thing that's very commonly seen in G6PD deficiency. And then again, those up and down arrows for the various things that you're going to look for in these patients. Right? The most accurate test for G6PD deficiency is G6PD level 1 to 2 months after an episode of the hemolytic anemia. Right? After things have gone back to normal and they're not, sick or whatever, or the inciting factor, whatever incited the hemolytic anemia, once that's resolved, you can try to see is G6PD levels back to normal. If it's not, then they have a deficiency. Right? Often normal during an acute episode because G6PD deficient red blood cells are hemolyzed first. So you want to check after the acute episode is done. But of course, the initial test always, patient comes in with anemia, you order CBC. Right? You can check for what's causing the issue. So here's a list of a bunch of medications that can often trigger hemolysis and G6PD deficiency. These are all very commonly tested, right? The ones you have to avoid. And anyone that has a history of hemolytic anemia, not even a history of G6PD deficiency. If a patient comes in and they tell you that they have a history of hemolytic anemia, you don't know for sure if it's G6PD deficiency or not for that patient. You just assume it is and don't give them these medications. Right? You don't want to give them these medications. We just talked about PNH, right? So again, they say that diagnosis can just be done by looking for these guys in flow cytometry. So flow cytometry is one of those things that most med students don't really know how it works, and even I've never really seen a flow cytometry device doing its thing. But basically what this is it's a beam, it's a laser beam that is going to look at each red blood cell individually to see if they have the CD55, CD59 on it. And then the flow cytometry device will divide those cells that don't have it versus the ones that do have it. When you run this person's blood through the flow cytometry device, if you notice that none of them have CD55 and 59, then it's evidence that they have PNH. Prednisone is the best initial therapy. Allogeneic bone marrow transplant is curative. You just give them a bone marrow transplant where the bone marrow is able to make good red blood cells that have the GPI anchor and the CD55, 59. You could also use this medication, which is very rarely tested, eculizumab. This is in step 1 pharmacology as well. This medication is actually a complement inhibitor. But you don't really want to do this, right? Because you need your complement. If you inhibit your complement just because it's killing your red blood cells, well, of course, yeah, that's a big deal. You don't want your complement to kill your red blood cells. But then now your complement also can't kill all the other things that you need it to kill. Most notably, you need it to kill Neisseria, right? So then you would have to probably also give the patient prophylactic antibiotics or something and advise them to not do things where they might be exposed to Neisseria infection. Hereditary spherocytosis, as we saw in that image right above, and this is it. That's how it looks like. Really, really round, wide red blood cells. Even the other red blood cells that aren't that spherical will mainly have a very weird shape. See, you could tell that pretty much 100% of these red blood cells are perfectly round. Red blood cells aren't perfectly round all the time. Some of them are usually oval shaped. Right? These are all perfectly round because they've been dilated. So it's like no longer having that donut shape. It's got a 3D spherical shape now. Right? So that's why, for example, if you look at this one here and any of the other ones that tend to have some pallor, even then they don't look so normal. The 3 that I circled have central pallor, but they don't look so normal. The pallor is weirdly distributed. Right? It's supposed to be, I would say that the most normal looking red blood cell in this image is probably this one right here. Right? In this one, the pallor in the middle is kind of faint, which kind of makes you think that maybe it is actually more spherical and the faint part is just really deep. In a red blood cell, when you hold it, the center part that is causing the pallor is very thin. The outer parts are fat, and those are the parts that carry the oxygen and stuff. So this doesn't look like it's very thin over here. This is the most normal looking red blood cell. This guy. Let me see, where were we? So that's hereditary spherocytosis. Here there's a couple other tests now. Right? So there are different things you can order. For step 1, they mentioned this as well. There's this thing called the eosin 5 melamine flow cytometry. This has now been replaced with the osmotic fragility test, which is a lot easier to do. And then there's also the acidified glycerol lysis test. Right? So this is what they were doing in that question we just looked at, the acidified serum test. Right? It was positive here in these people too because their red blood cells were very fragile. Right? That's what it tests for, the fragility. They put this thing here to confuse people into thinking answer choice A is the answer, which would be for spherocytosis. And a lot of people did fall for that. Right? But it wasn't spherocytosis. In a person with spherocytosis, you wouldn't really have dark urine in the mornings. There's no reason for it to be only in the morning, right? Because in PNH, it's nocturnal and happened overnight, so in the morning when they finally woke up and urinated, there was a lot of blood. So for spherocytosis, you could do any of these fragility tests to see if the red blood cells are very fragile. Because they're all puffed up like a balloon, as soon as you do the acidity test or the osmotic fragility test where they add solutes into the blood to see if the blood pops, it'll pop. Right? The blood will pop. It's not supposed to pop. You just manage it with the splenectomy. That'll stop the hemolysis. And then you do chronic folate replacement to assist in red blood cell production. Remember that although folate deficiency can lead to megaloblastic anemia, hemolytic anemia can lead to folate deficiency, because with your hemolytic anemia, you're trying to replenish all the heme that you lost. Patients with hereditary spherocytosis have a characteristically increased mean cell hemoglobin concentration, MCHC, will be high, as you can see here. That is pretty critically special about these people, and elevated RDW, red blood cell distribution width. Some red blood cells might look normal, some are going to be very spherical, so huge difference between red blood cells. That's all that means, right? So you have to make sure you're ready for that. Each of these up and down arrow things are going to be on your test, and they're going to be in a long list of answer choices. And the only differentiating thing between two final answer choices will be one thing, whether it's high or low. So you have to remember what's high, what's low. But better than remembering it, you should just understand it, because each of these things are actually measuring pretty obvious things. Sickle cell disease, autosomal recessive disorder, there's a mutation in the beta chain where GLU was replaced with valine. Right? Glutamate, which is acidic, was replaced by valine, causing production of abnormal beta globin, resulting in the production of hemoglobin S rather than hemoglobin A. So in these people, you're going to see hemoglobin A2 and hemoglobin F, which is fetal hemoglobin, are still being produced, because those are going to be more functional than the normal hemoglobin A you're supposed to have. The hemoglobin A has the alpha and beta chains in it, right? But now that you're unable to make beta chains, you're going to make hemoglobin with just alpha chains in it. That's why it's called hemoglobin A2, too much alpha. Or you might just keep your fetal hemoglobin. If this child is born with sickle cell, they're going to try to retain fetal hemoglobin productions for as long as they can. But it doesn't remain forever. And fetal hemoglobin isn't exactly the best for us, like as adults. It's not something that's preferable. The homozygote has sickle cell anemia, right, HBSS, and the heterozygote has sickle cell trait. Both patients, though, will still have sickle cell symptoms. It's just that the homozygote is going to have a lot more. Signs and symptoms are caused by decreased red blood cell survival and a tendency of sickle cells to aggregate and cause vaso-occlusion, which is really bad. Vaso-occlusive disease is painful and it's difficult to deal with, and often can lead to the cause of death. So if we go back here to look at it in a little more depth, we're going to see sickle cell. Let's see. Right here, sickle cell. Right, so the things that it can cause, the things that can occur, complications, right? You can have aplastic crisis, transient arrest of making any more red blood cells due to parvovirus B19, autosplenectomy, where this is usually the case scenario for most people with sickle cell. Their own spleen basically dies because the body realizes they don't really want it. Because of that, they end up having hollow jolly bodies. Right? You're going to see hollow jolly bodies in their red blood cells. And when you don't have a spleen, you get more risk of infection with encapsulated organisms. Now, usually in the real world, when we take somebody's spleen out, we'll make sure we vaccinate them against all these encapsulated organisms. But on STEP, apparently we don't. So when you read a question where they tell you a patient had their spleen taken out, don't assume that when their spleen was taken out, the doctor was also intelligent enough to give them the vaccinations they needed. Apparently they don't. Right? This has been an ongoing difficulty with NBME as well as UWorld questions, because we should be confidently able to assume that when the splenectomy was done, right, not an autosplenectomy, but when an actual splenectomy is done, like with the patient with spherocytosis, that we will vaccinate them against all the encapsulated organisms. But on STEP, you don't make that assumption. So on STEP, you pick S. pneumoniae as an answer choice for patients who had their spleen taken out. Right? Splenic infarct or sequestration crisis can occur. Salmonella osteomyelitis is the most common type of osteomyelitis a patient with sickle cell will present with. Painful vaso-occlusive disease, right? Anywhere you have blood vessels, which is everywhere, your red blood cells can get in there and just get stuck. And this can occur in the penis as well, which causes priapism. Really, really problematic. they can get acute chest syndrome, which can kill them, right? Respiratory distress, new pulmonary infiltration on chest x-ray, common cause of death. These pulmonary infiltrations on chest x-ray will be without a fever. So that means that they don't have pneumonia or some other kind of thing that's causing their chest x-ray to look weird. It's also not acute respiratory distress syndrome, so be very careful to not pick that, right? It's acute chest syndrome. And they can get avascular necrosis, especially of the femur, and stroke. Many ways for them to die. How do you prevent these things from occurring? You do this thing called hydration, and they mentioned that here. But this doesn't mean drinking water. Hydration is something you have to go into a hospital to get it done, where they're going to basically pump your body full of things that will cause red blood cells to not clump together, right? And similarly, you can assume that if a patient is dehydrated because they haven't drank water or they were running for a long time and they sweated all their water off, that they're going to get vaso-occlusive disease and die. Right? So sickle cell patients cannot be athletic or they'll die. Right? And then, of course, you could continue using hydroxyurea, which aids in the production of more fetal hemoglobin because it's better than the hemoglobin they're going to make themselves, HbA2. One of the other weird things that you can see in these patients is this crew cut on skull x-ray, because their bone marrow is going to try to expand to do more erythropoiesis. That's the common theme of all your hemolytic anemias, right? Your body is going to try to make more red blood cells to replenish the red blood cells it's losing. That causes a weird looking skull x-ray, right? Crew cut. So let me see, I think I had a picture for that somewhere before. But you can Google a crew cut. Right here, this thing. You see it in thalassemia as well. See, so it's like the crew cut is the haircut that people get where it's just hair in the middle, right? Just hair right here in the middle. That's what they're talking about, crew cut. So you can see this guy's skull X-ray is looking really weird, almost porcupine-like, because in their skull, their bone marrow is becoming more active than it usually is. Our skull's bone marrow is not that active in a healthy individual. But in them, it will be. Beta thalassemia and in sickle cell, both of which share something. They share the fact that the beta chain is not made that well, right? So here I wrote in step 1 book, right, MCAC is going to be very high in hereditary steatosis, very big deal for them. Their RDW is also going to be high, pretty big deal. And PNH we talked about, and sickle cell we're looking at right now. So these are the basic things you want to make sure you go back and revise, right? Clinical workup, we talked about this. We talked about the eculizumab. Always give iron and folate to pretty much everyone. You know, there's no real harm in doing so. Painful vaso-occlusive disease, right? We talked about these things. They can, and again, this vaso-occlusion can occur anywhere. So they can also get this thing we talked about in GIT, the mesenteric ischemia, which is an MI, right? It's like an MI, same kind of MI you would have in your heart. You can also get it in your blood vessels that supply, like your SMA, IMA, celiac artery, the blood vessels that supply your GIT system. If they're occluded, of course, that area that they supply will not get blood, and then mesenteric ischemia occurs, right? So acute abdominal pain. Let me see what else is here. Predisposed to infection, okay. Yeah. Talked about all of that. Of course, the best initial test is CBC. Hemoglobin electrophoresis is hemoglobin electrophoresis is probably going to be the answer choice you want to pick if the question is literally about sickle cell or the thalassemias, because those are both inheritable disorders, right? Both of them are inheritable disorders, and I think I mentioned earlier that when I did my hematology and oncology rotation, that we had a lot of patients, most of them were African American, and the majority of the time, whenever they came in, you had to get very comfortable with them as a practitioner, and you had to get confident in their sharing with you their romantic relationships, because if they find someone who they would maybe want to marry or have kids with, then you want to make sure that they do a hemoglobin electrophoresis for their partner, because if their partner also carries the trait, then they're just going to end up having a risk of having kids with the disease, right? And that's pointless to do that, right? Very unnecessary. And if they choose to continue and have kids with that partner, then that's pretty selfish of them, right? And that's not a good idea at that point. Here they're showing you acute chest syndrome. Again, this chest X-ray really isn't that diagnostic. This is a pretty bad chest X-ray in my opinion. This is a frontal chest X-ray of a pretty young guy, 19-year-old woman with sickle cell disease and acute chest pain. Note the bilateral lower and mid-lung opacities and mild cardiomegaly. So I told you guys that you can always figure out cardiomegaly by using this angle here, that the heart should never really pass the line that you drop from here. So you can see clearly this portion right here is passing, right? So that's your cardiomegaly. And in this person, you're noticing a lot of haziness here, and here. The top is fine. This area is okay. This area is okay. But the rest of it is all very hazy here and here, right? In a better X-ray, you would also be able to tell that they don't have any pleural effusion, which means looking for this angle right here, it should be nicely visible, right, on both sides. This is the normal gas bubble you have in the fundus of your stomach. That's fine, nothing weird about that. And that's basically all you're seeing here. So very important to catch these things. So if you get a 19-year-old with sudden chest pain and it's not due to coronary vascular disease, it's not angina, it's acute chest syndrome, right? And they probably have some kind of sickle cell issue. They go on to then tell you, is this still about sickle cell right here? Yeah, managing chronic disease, right? So this is what your questions are going to be about. Management of chronic disease. First of all, treat with hydroxyurea. You need them to make more fetal hemoglobin so that they have good hemoglobin that'll work, right? Just one thing though, hydroxyurea is teratogenic and may cause mild myelosuppression. So it's very important to monitor the white blood cells, right? Even though it's teratogenic, we're not really caring about the fact that this fact that hydroxyurea is teratogenic isn't here because the person might be pregnant. No, this is about the person themselves. It's teratogenic because of its myelosuppressive capabilities, but the myelosuppressive capabilities will also harm the adult itself, right? So hydroxyurea has a risk factor associated with it, but the benefits are better than the risk itself. If hydroxyurea does not prove effective, chronic transfusion therapy is done. And remember the thing with chronic transfusion, you can cause iron overload, right? So that's another thing you have to watch out for, right? Iron overload. And folate supplementation is often required to prevent macrocytic anemia, right? Like I said, hemolytic anemia causes you to have more folate demand. More folate demand can make you run out of folate. Now you can also get megaloblastic anemia, right? So that's what you're preventing. You have to meet the demand of folate. Risk for septicemia in febrile patients or in leukocytosis, so you have to give antibiotics, usually ceftriaxone. You could just pick levofloxacin or moxifloxacin as well, but ceftriaxone usually does the job. You don't want these patients to end up having osteomyelitis, right? Now people live their life, so they can go do things that can get them infected, and there are so many ways to get osteomyelitis. I mean, you could literally be bit by a cat or scratched by a cat, and that can lead to osteomyelitis. In these patients, it can occur in healthy individuals too, but the chances are significantly higher in these people. And then, of course, prophylactic vaccinations, which are a huge topic in step 1 at CK. Right? You're going to have questions where they're going to tell you what should you do for the patient, what's the best thing you can do to care for this patient. Vaccinate them. Right? That's one of the best things you can do for any sickle cell patient you have. Vaccinate them against things as much as possible so they don't get infection. Right? Especially because they're going to have that autosplenectomy at some point, and their spleen is going to die, and then they're at risk to infections from encapsulated bacteria. Treat recurrent cholelithiasis with cholecystectomy. So why would they have cholelithiasis? So now this is due to the fact that when you have a lot of hemolysis, another kind of stone you can get is a heme stone, right? Not just a bile stone, but a heme stone. There were two different types of stones you could get. And we saw that back in GIT. So let's go back and look at it one more time just to make sure we remember this. Let's see, it should be this way. No, the other way. Stones. Yeah, so here we're seeing all the things that occur with the hemolysis, more bile, more bilirubin, and then cholelithiasis. Look, cholelithiasis can be due to two things. You could either have a cholesterol gallstone, or you could have a pigment gallstone, due to a lot of unconjugated indirect bilirubin, which actually forms because of hemolysis, right? Pigment stones due to hemolysis. all of that unconjugated bilirubin precipitates calcium bilirubinate, which causes heme stones. So they're going to get, these sickle cell patients and anyone with chronic hemolytic anemia is going to get recurrent cholelithiasis. This is a very nice, tricky topic to throw at students, because many students tend to forget that, all that heme can cause cholelithiasis, that you can get pigment stones, right? So cholecystectomy will need to be done as well. So a question might tell you that, maybe you did the splenectomy for your sickle cell patient, you vaccinated them, what's the next best step? Do a cholecystectomy too, because they're still going to have hemolysis occurring. Right, so again, that's something you have to pick as an answer if the situation presents. Management of sickle cell crisis is usually just with two things: hydration and pain meds. Right, you give them pain medications and you do IV fluid rehydration. Antibiotics if there's infection, of course, you don't have to be told that. Anyone that has infection, you give antibiotics. If there is concern of a vaso-occlusive crisis progressing to acute chest syndrome, initiate aggressive hydration. The point of this hydration is to cause all the red blood cells to have a lot of water in between them so they don't clump together. Right? Aggressive hydration, antibiotics, and incentive spirometry to make sure that you can see that their volumes of air everywhere is fine, that they're not having respiratory distress. Keep the sickle variant less than 40%. This can be done with simple transfusions or, if necessary, exchange transfusion in an ICU setting. Bronchodilators may be helpful, right? Because if they stop breathing, they'll die. So, of course, that's true for anyone. So what they mean by keep the sickle variant less than 40% is that you want to take out their sickle blood cells and give them normal red blood cells. If more than 40% of their red blood cells are sickle, if half of your red blood cells are sickle, they're all going to come together and you're going to get vaso-occlusive crisis everywhere and you're going to get acute chest syndrome. Right? No treatment is required for sickle cell trait, which you have to remember. If you get a question where the patient has sickle cell trait, usually the patient will be just fine. They're okay. They might have little minor problems here and there, but overall they're fine. And then the question says, what's the next best step? Nothing. You don't need to do anything. Right? This is literally its own circle right here. You have 3 circles for treatment. The third circle says don't do anything. For someone with just sickle cell trait, they should be okay. All right. And let me see now the remainder of this. Yeah, so the last thing here is your autoimmune hemolytic anemias, AIHA. Now, autoimmune hemolytic anemia, that is the one where you're going to have antibodies, right? So you're going to do a Coombs test and you're actually going to see antibodies because it's autoimmune. Let me see where that starts. Right here. Right, so this is called an extrinsic hemolytic anemia, which means that something else, not the red blood cells itself, not something inside your blood vessels, something outside is killing your red blood cells, which are your antibodies. Right, so of course this is going to, when you do the direct or indirect Coombs test, you're going to see antibodies, and your red blood cells will agglutinate when you add the Coombs reagent. If you forget how the Coombs reagent and everything works, you can come back here and check that out. The direct Coombs test is where you use the patient's red blood cell, right? You add the Coombs reagent, which is anti-human globulin antibodies, right? These are antibodies that are supposed to attack the green thing. The green thing, or the antibodies that are attacking your red blood cell. So you see how they all clump together now? All right, and then in the indirect Coombs test, it's indirect because you don't actually look at their red blood cells. You take their serum, you add normal blood to it, and the Coombs reagent, and what you're going to see is that these antibodies are going to kill the normal red blood cells, and then these antibodies are going to stick to these antibodies, creating this nice circle once again. Everything clumps together. Right, so indirect because you're not looking at red blood cells, direct because you are looking at the patient's red blood cells. All right. You could have either warm or cold agglutinins. The warm ones are chronic anemia seen in lupus or some kind of blood cancer like CLL, as well as many drugs. Methyl dopa is the only one they mention here. There aren't really many questions whether to cause it by a drug. It will usually be someone with lupus. The cold agglutinins are due to Mycoplasma pneumoniae or mononucleosis. Right, and again with CLL as well, but CLL will have its own set of questions, so don't worry about that. When you study Mycoplasma pneumoniae, that's one of your atypical pneumonias that causes walking pneumonia, where the patient looks okay, but as soon as you do the chest x-ray, it looks terrible, like you're just wondering how they're even walking around. That's why it's called walking pneumonia. And in that sketchy microimage, there is snow, because there are cold agglutinins, right? These red blood cells can agglutinate and cause painful blue fingers and toes with cold exposure. Very similar to Raynaud kind of thing. All right. So what are your autoimmune hemolytic anemias? Well, it could be microangiopathic or macroangiopathic. These guys are different though. We talked about some of this, right? So the micro ones did have antibodies, right? DIC, not DIC, but TTP, and actually TTP was the only one that really had antibodies, right? That was the only one. The other ones just have hemolytic anemia because of the things that are in there. For example, remember with TTP, the antibodies caused you to make these thrombotic little things within your blood vessels that were then messing up the red blood cells as it was passing inside your blood vessels. Right? These are things inside the blood vessels. So all of these, DIC, HELP syndrome, hypertensive emergency, they're all conditions where something is messing up red blood cells inside the blood vessels. Macroangiopathic was the heart valve stuff, a bad prosthetic heart valve, right? But the only one that'll really have a direct Coombs test or indirect Coombs test that's positive is one of these case scenarios. That's lupus, CLL, Mycoplasma pneumoniae, mononucleosis. 4 case scenarios. That's it. Right, so they tell you here 2 types, warm and cold agglutinins. They list out the same things. They've listed out more of the medications here. The most commonly thing you're going to see are the penicillin and phenytoin. If a person is actually, susceptible to having AIHA, autoimmune hemolytic anemia, and they tell you that all you do is just do the Coombs test, and then if it's mild, no treatment is necessary. Very important to remember that. You don't pick an answer choice anything other than this. If this is an answer choice though, usually we're very hesitant to pick it. Not here. You always want to, and this is true for any case scenario. If your patient comes in and their problem isn't so bad and their symptoms are not really that severe and everything's okay, then don't really do anything. Don't do anything. All right, warm IHA is treated with steroids. Recurrent episodes respond to splenectomy. Severe non-responsive hemolysis is controlled with IV immunoglobulins. So that's your warm. For severe cold AIHA, that's actually managed by avoiding exposure to the cold, so keep the patient warm, plus or minus the use, once again, of rituximab, right? Anti-CD20 antibody. The last thing here is just your aplastic anemia, failure of blood cell production leading to pancytopenia, so they're also missing platelets and white blood cells, caused by destruction of your bone marrow cells. It may be hereditary, as in Fanconi anemia, where genetic analysis will show chromosomal breaks. May have an autoimmune or viral etiology, like usually parvovirus B19, but could also be HIV, Epstein-Barr, CMV, or hepatitis. Usually just parvovirus B19 with the slap cheek fever and all that. Or may result from exposure to toxins like solvents, insecticides, benzene. Of these 3, I would probably assume benzene. Could be due to radiation, could be due to sulfa drugs. Not really something I've seen. Propylthiouracil also causes this, and carbamazepine. Both of them are known to possibly cause aplastic anemia. The way this gets tested with drugs itself, the way this is tested is that when you prescribe one of these drugs, they'll ask you what else should you do. You should be regularly screening them and doing regular CBCs to make sure they're not developing aplastic anemia. Aplastic anemia in drug-related case scenarios doesn't just develop overnight. So you'll catch it as they continue to slowly make lesser and lesser red blood cells. Right? Patients are pancytopenic with symptoms resulting from a lack of red blood cells, white blood cells, and platelets. So they get petechiae. When you don't have platelets, that happens. Right? They get bruising. They get bleeding that won't stop because they don't have platelets to cause primary hemostasis. Diagnosed mainly clinically, and then of course you can order the easy CBC. The most accurate test is to do the bone marrow biopsy, where you'll basically just see fatty infiltration, right? Hypocellularity. There's no cells. Even though the bone marrow is usually full of cells, you're making cells in there. But in these people, it will just be full of fat. Treatment is supportive. Do the blood transfusions, give them platelets, give them whatever they're unable to make. Consider allogeneic bone marrow transplant in young patients. In severe cases, in patients without a stem cell donor or patients too old for a bone marrow transplant, immunosuppressed with cyclosporin, anti-thymocyte globulin, and L-trompopag to prevent autoimmune marrow destruction. Tacrolimus is an alternative to cyclosporin if they can't take cyclosporin for whatever reason. Remember, these medications have critical side effects, right? Very critical side effects. It was discussed in the first page of immunosuppressants, right? All the things these guys do. Cyclosporin and tacrolimus work very similarly, but cyclosporin is heavily nephrotoxic. Tacrolimus is also heavily nephrotoxic, but there's one key way of differentiating which one you should take. It's the risk of diabetes, right? Tacrolimus increases the risk of diabetes, so you don't give this to someone who has diabetes. Cyclosporin is very neurotoxic, causes gingival hyperplasia and hirsutism. So if your patient already has issues related to one of these three issues, or if they have excessive hyperlipidemia, you don't want to give them cyclosporin. Right? These are both calcineurin inhibitors. They're both nephrotoxic, and if you need it, you need it. So, at that point, you weigh benefits over risks. And in these people with aplastic anemia, they need it. All right. So that finishes basically all of those anemias. There's a bunch of practice questions throughout the book, which we'll revise in the next session. I might be live Thursday, but usually we now meet Friday, right? So I'm not online tomorrow, but Friday we'll definitely meet. If I do go live Thursday, I'll definitely make sure to let people know as soon as I wake up Thursday morning, or if I see my schedule Wednesday, then I'll let people know Wednesday. And yeah, but make sure you go through these questions. And as usual, when you're seeing these questions, if there's anything in any of these questions that maybe doesn't ring a bell, you don't remember it, or you forgot what it is, like if you don't remember Fanconi anemia and what that's all about, then go back to your first aid from step 1 and revise that topic. All right, and that's it for now. And then next time we'll continue on into thalassemias, and we'll look at these questions as well. Enjoy your night, guys.